Now, this session on management of hypogonadotropic hypogonadism promises to deliver valuable insights from leading experts in this field. To guide us through this session, we have our esteemed chairperson, Dr. Ashima. It is my pleasure to invite Dr. Ashima to the stage, and please join me in welcoming her. Dr. Ashima is currently working as professor in Department of Pediatrics, Maulana Azad Medical College, New Delhi. Her areas of interest are born disorders, general pediatrics, and medical education. Welcome,
Thank
Dr.
you.
Ashima. The session is now in your capable hands.
Thank you, Dr. Anjali. I think most of us are here to hear from the experts, and we are very fortunate to have Dr. Nalini Shah, Professor Nalini Shah, who's Professor Emeritus at KEM Hospital. Ma'am actually makes the most complicated topics simplified for us. So, with her, we have Dr. Manjari Karlekar, who's also an endocrinologist, currently working at Zen Multi Speciality Hospital, Chembur. Areas of interest being diabetes, thyroid hormonal, osteoporosis, and pituitary gland disorders. So, as I declare the session open, I think we are very fortunate to have two very learned people here for the Meet the Experts session. And as they take us along, understanding management, diagnosis and management of hypogonadotropic hypogonadism, I think it would be the interaction from the audience will be more than welcome here. Instead of that can actually help most of us clarify our doubts. So please feel free to stop. Maybe you can raise your hand if there's at any point you would want more discussion and more clarification from our experts, so that we make the best use of this time. Over to you, Dr. Nalini and Dr. Manjari.
Yeah, sure. Good afternoon, ladies and gentlemen. It's interesting. It's always interesting to do Meet the Professor session, and these are meant to be, though very structured, kind of a outline of the whole program, because this has got an hour of dedicated time to it. I would kind of consider it to be informal enough that if any time anybody has any question, just please be comfortable enough to raise it. It's far more useful to make it interactive rather than just a sort of a monologue from both our sides. So this is the way we've constructed it. We want to give you some kind of a background as it relates to his physiology. And then we've taken sort of, the diagnostic challenges which are associated with this particular entity. And then we've highlighted cases in which these learned points from the previous two aspects are applied, and how much of possible errors which can creep in if you just kind of focus yourself onto cutoff, saying, I mean, all of us are very centric to say, what is a cutoff for this test and what is a cutoff for that test? There is something which is beyond cutoff, is what we have specifically chosen as case capsules, which Manjari will be sort of trying to, sort of take us through, only as a learning curve. That cutoff is not be all and end all. It cannot be. It cannot surpass your clinical judgment. And that is the importance of understanding the whole of physiology and its application when you're talking about patients and their management as it relates to hypogonadotropic hypogonadism. So let's begin with it, right? So this is a very typical example. This is a 14-year-old boy, and though he has been sort of on the shorter side in the class, he's been doing very well so far in his life, and parents had sort of accepted that he's a little on the shorter side, but he's a very normal child. At 14 years, they kind of wake up because the peers are now going through puberty, and obviously this child has not entered puberty, and the parents want to understand, is there a problem with him in terms of not having puberty? And that is the commonest problem that you encounter, which you want to kind of tell the parents in terms of, is there a problem with this child? And what kind of problem is it? and how do we really address it? So how does one clinically approach this kind of a scenario? Do we really need to use clinical parameters, the biochemical parameters, and is genotyping also necessary in group of some of these patients? And most important, from parents' point of view and also from the clinician's point of view, how do you really manage these individuals? So we are now talking about the clinical approach, and as we talk about clinical approach, we are very comfortable with this background of information that puberty is an extraordinarily well governed event starting right from the fetal life. And we know that, right? It's a maternal HCG which is governing the entire development in the male fetus, especially in the first 12 weeks of life. And it's only at around 14 to 15 weeks that fetal pituitary gonadal axis kicks in, and somewhere at around just before birth to early part of infancy, we have a first phase of mini puberty which comes in. Also, at around puberty, we have the typical events which are orchestrated, which are extraordinarily well synchronized events leading to ultimately timely growth of both Leydig cells and Sertoli cell, each of them serving a very distinctive kind of a function. And we are very aware of this, we are very comfortable with it. So, and we are also aware with these definitions that any child who is not entered puberty at 14, we are going to call it delayed puberty. But that really doesn't mean that a child who comes to me at 4 years of age with some red flags, which Manjari is going to sort of bring together specifically in one of our case scenarios. I'm not going to sort of say that, before 14, I cannot make a diagnosis of delayed puberty. In fact, even in infancy, with help of red flags, I am going to suggest that this is a patient who's got problems with puberty and its governing axis, and we need to perhaps do something about it. So 14, though it's an age group that we are talking about, at each stage of life, right from birth to infancy to childhood to even later childhood, 8-year-old, 10-year-old, we are going to address this question in various forms. And that's what our case scenarios are going to elucidate. Also, over here, we can sort of look at this axis, which clearly shows the red line, and that is depicting mainly how the very classic scenario as it relates to constitutional delay in growth and puberty evolves. Late start, a slow but continued rise in volume of testes, and instead of sort of completing puberty at 14, 15, these children will linger on to continue their march into puberty right up to 16, 17, or 18 years of age. And that's not at all uncommon. Also, puberty or its presentation can come in different age, which is what we elucidated earlier. It can come at the early infancy with micropenis, unilateral or bilateral cryptorchidism. It can come at the age of puberty itself, where it comes with either partial or complete absence of puberty. And these are extraordinarily important kind of statements, because these are the very case scenarios which are totally going to give you very disrupted messages when you try and conduct the test on them to find out whether they are really dealing with any problem related to their HPG axis. And this is going to be very, very important as well. It can come with a fully developed pubertal status and infertility, which is the only problem with which the patient presents to you. It can classically present as delayed but complete march into puberty, what we call as a constitutional delay in growth and puberty. It can come as delayed puberty or hypogonadotropism, only to reverse sometime later in adulthood to completion of puberty, and that's a very well described phenotype, or an adult who's got full blown puberty, which is normally developed, now goes to reversal and comes with hypogonadotropic hypogonadism. So these are all the different scenarios and different events with which a patient can present, and these are well described, and all of us encounter it. We have specifically encountered this because as a department, we've always catered to both pediatric, adolescent, and adult endocrinology. So, if I talk about the commonest causes, these are the four scenarios that you're going to encounter. It's either, if you look at the central to patients, it's either just a self-limited, a physiological delay in onset of puberty, what we call as a constitutional delay, or a permanent state of hypogonadotropic hypogonadism, which are the closest differentials that you encounter. And at each of the extreme, on the extreme left of my hand is functional state of hypogonadotropic hypogonadism, which presents because of underlying systemic disorders. And it's not at all uncommon in clinical practice to encounter somebody who's got, for example, chronic renal failure coming to you for the first time at puberty saying lack of development of secondary sexual characteristics. And that is one of the fair amount of referrals that we have seen, and that would always remain as a first point of exclusion when you're looking at patients with pubertal assessment. You can also have, coupled with all this, a state of hypergonadotropic hypogonadism, a very important distinction that you definitely want to achieve, because your management principles are going to be extraordinarily different in these two scenarios. This is a slide which just puts together the previous pictures in terms of prevalence data. The commonest reason that you encounter with delayed puberty is constitutional delay in growth and puberty, and that surpasses all other etiological factors when you encounter referral for delayed puberty. And all the rest, depending upon your referral practice or referral bias for that matter, are going to be encountered as well. So if I talk about the functional state of hypogonadotropic hypogonadism, we are referring now to systemic illnesses. We are referring to something like anorexia nervosa as a state, which is a state of poor growth, plus minus poor weight as well as one of the scenarios, and perhaps associated with retarded bone age, depending upon the age group of the child. So if you are encountering a scenario of delayed puberty, it's imperative that we just have a basic workup available for systemic screening. And the minimalistic menu that you could perhaps use is blood counts, bicarbonates, creatinine, TTG, IgA, and TSH. This would be the minimalistic menu. And coming from an economically challenged background with which we have worked in our department, we are very conscious of our menu options. And that's why we always sort of ask ourselves, what is the incremental benefit that you're going to get in just clubbing more number of tests over there? So this would be the minimum number of tests that we would kind of work with, and always exclude that as a primary reason which could be hampering the clinical scenario of delayed puberty. It is always clinically feasible in many of these children to pick up a lot of clinical signs as well, which would be a pointer to the underlying systemic causes, and that would always depend upon which disease entity we are really encountering. Having talked about the systemic scenarios and perhaps excluded that effectively, we would be then talking about a scene which is hypogonadotropic hypogonadism versus hypergonadotropic hypogonadism. And even in that, again, clinical cues become really useful. Arm span, which is much more than the height, is important. Perhaps this distinction gets masked in hypergonadotropic hypogonadism because of the long-leggedness of these individuals, which is actually pre-pubertal, and it's really nothing to do with puberty alone or per se as a parameter. And that is one thing which is going to mask the difference between arm span and height in hypergonadotropism in these children. Also, presence of gynecomastia is important cue to work with. Though even in hypogonadotropic hypogonadism, you can get gynecomastia, these are usually milder. Whereas in hypergonadotropic versions, we see a much more prominent symptom complex as gynecomastia, as in fact, it could be one of the presenting symptoms because these patients can be very embarrassed to talk about their secondary sexual characteristics or infertility, and they would simply come and tell you that their chest looks very prominent, and that's one of the very dominating feature that you encounter in hypergonadotropic hypogonadism. And of course, your biochemistry comes to you in a good stead in these individuals. So the minute we have elevated gonadotropin levels, we know that we have looked after the state of hypergonadotropism, and we are now sort of going to exclude them from our discussion, which means that we are now looking at inappropriately low or normal gonadotropins in presence of low gonadal steroids. And that typically will come from either a physiological self-limited delay in puberty or a state of permanent hypogonadotropic hypogonadism. And that's, of course, very important distinction between the two, because in one, you may try to push the puberty or pull the puberty, but in other, you'll have to do a lot more than just pushing and pulling. And that's one thing that you want to think about. Again, in that, we want to be sure whether this is just a congenital entity of isolated hypogonadotropism or it's a part of multiple pituitary hormone deficiencies. Is it congenital or is it acquired, and hence perhaps a sinister cause which will require, in addition to the pituitary hormone management, far more going from the patient's point of view? So that becomes again very important for us, and that's again going to require a little bit of additional clinical assessment and pertinent investigations. But before we go to that, maybe if there are any questions based on what we've talked so far in terms of diagnosis or a possibility of suggesting delayed puberty in different scenarios and its approach, would there be any questions that one should be wanting it to be understood in bigger details, because maybe we've curtailed some amount of details over here? Shall we proceed? Yeah. Right. So in that case scenario, I think one of the things that we always go through is again re-examine the patients to figure out whether it's an isolated hypogonadotropism or it's an acquired state of hypogonadotropism. And what you really encounter are two category of signs. One is a sense of smell. It's very important to ask this question to even children, and we've learned it a hard way. We've gone back and asked these questions to our children, and they've come out with some weird stories to tell us about it, and we kind of realized that these children always were missing sense of smell. They themselves were not aware of it, and they kind of, once we started questioning it, they kind of came out with it in a very authentic manner that they always lack sense of smell. It's important to directly ask this question. Very systematically, we used to do UPSIT, a sense of smell test in these individuals, but we realized that in borderline scores, it becomes very difficult to assign them as hyposmia or normosmia. And we have just now boiled down to asking a child whether it is anosmic or hyposmic. And that stands in a fairly good stead, and we've stopped doing the smell test completely for our children. So one is a sense of smell that you want to find out from your children and ask the parents as well. Second thing that we always want to anchor is a non-reproductive phenotype, and you will be surprised how useful and how helpful it tends to be. Of course, signs like renal agenesis, you're not going to find out from the child or from the family. It's more investigation based, and it's not something which is going to have any symptom complex associated with the child who presents at 14 or 15 years of age with delayed puberty. Synkinesias are again something which children know themselves, but they were never aware that there is a problem. But the minute you ask them, they can make out. Or even a brother or a sister of the patient, they are able to tell you, yes, he always does this. When he's moving his one hand, his other hand starts moving automatically. And that we've encountered as a history many times when you directly go and question these individuals. And of course, going through the examination for all the midline defects, the dental defects, the polydactylies, the hearing defect as a history, and what is most striking is in different groups of hypogonadotropism, you can encounter superimposing non-reproductive features. But generally, in a normosmic individuals, you don't get many non-reproductive features beyond the reproductive features, which are micropenis and varying degrees of cryptorchidism. So that has been one of the important learning curve that we think we should share with you. We've also seen many syndromic features associated with hypogonadotropism, like this child having heterochromasia, also having white flock of hair, which was not something which was picked up, but because of his eyes, we could pick it up. Also, this kind of retinal changes which were picked up on fundus examination in a child who had an obvious evidence of cerebellar ataxia. And it also remains to be seen that they may present with a neurological sign first, and hypogonadism is something that is picked up incidentally. They may not come a priori with hypogonadism, and that's also another thing that you need to remember. And our last case, if you can see, the 4H syndrome, who never thought anything about his teeth, but if you look at his teeth, you know that it's truly abnormal, and it is add-on to your syndromic component of 4H, which is very, very easy then to pick up a state of hypogonadism. So even looking at these external cues will be aids in figuring out your diagnosis in these group of individuals. The family background and mode of inheritance is also quite important, because some of these genetic defect or genogenetic issues which are underlying causes of hypogonadism, and depending upon what kind of spectrum that you're dealing with, and we'll just come to that in a bit of a detail, they could be either X-linked recessive, autosomal dominant, or even autosomal recessive. And that is another thing that we have learned, and we kind of use it even in the family members who may not be coming forward towards presence of a clinical problem. And what we also understand and what we've learned is that the spectrum of the reproductive phenotype can be different in different family members. Some family member may have hypogonadism, whereas some family members may be just affected by sense of smell, and they can be completely fertile individuals. So it's worth understanding each of these phenotypes and their prevalence in the family members. And again, that was one of the learning curves that we went through. And when we kind of went through all our genetic data, which was initially done by Sangering, and then we went on to do NGS as a clinical panel. And you know that the clinical panel also keeps on extending. Now it is not, we had done it at the time when it was limited gene panel, and now it is about 40 gene panel that is being done as a clinical panel. So even this yield, which is as recent as 2022, is going to change. It's not going to be the last word which is really being held over here. Also, it would depend upon how severe is the phenotype of these individuals. This more severe is the pubertal delay, the more likelihood it is that you'll encounter the genetic problem associated with that. There are also some founder mutations, there are some hotspots of mutations that we've encountered, and with endogamous marriage, which are prevalent in our country, we have seen much more of autosomal recessive mode of inheritance based genotyping in our individuals, and that's also one of the learning curve. Again, may I just stop here and see if there is something which I've left in cold or not really explained properly? Yes, please.
Thank you, ma'am. Very nice presentation till now. Just one word about Waardenburg syndrome, which you have just showed a picture of that. They usually have, because they two of my cases they detected at birth only because white furlough had, and then we got suspicious, and on Bera found to have hearing deficit, which is what the commonest thing. So how common is hypo? Because after that they are lost to follow up for me. So how common is this hypogonadotropic hypogonadism in that? Because these hearing deficit, which is very common, so we picked up that, and white furlough cover had at birth. Even that was the clinch to the diagnosis that we are having a Waardenburg syndrome. Thank you.
So we really don't know the answer to that particular question, but I would kind of consider it most pertinent that these children are kept under follow-up, especially because there could be some, I would say, a window of opportunity. If these are severe states of hypogonadotropisms, you may even have to move in for your treatment right in infancy or in childhood. So I would keep it under follow-up, and I would keep it under monitoring and try and figure out whether they're really going through puberty as an event at an appropriate time, in an appropriate manner, and in a sustained manner. So complete spectrum could be part of it, right from no problem to full-blown problem which presents as absence of mini puberty to a partial puberty which has its appropriate age appropriate onset. So I really don't know the figure for prevalence. If anybody has any data for the prevalence in this particular syndrome, please do share it.
Thank you, ma'am. I think we have one more question there.
Hi, thank you, Dr. Nalini. I'm here.
Hi.
Hi. According to the identify the mutation in the patient with hypo, because we also do the research in genetic whole exome in this patient, and we also found 30% of the patients. And do you have any comments that why we found a little of the genetic defect, or any clue that which patient should be done for the genetic and can identify the mutation? Thank you.
So, in a very, we started this genotyping in our department quite some time back. I would say something like 14, 15 years ago in our department, and we've systematically studied this cohort for the phenotype, which is both reproductive, the non-reproductive, and their genotype, to start with a Sanger-based sequencing of the 4 main genes alone, and then moved over to NGS, which was clinical panel based out of 29 genes, I think. But what we really realized is that it's not easy to figure out phenotypically which of these patients are likely to have genotypic yield which will be stronger and hence may be subjected singularly for genetic analysis versus the other patients where the genetic yield is going to be poor. By and large, what we really figured was the more severe is the reproductive phenotype, the more likely it is that you will pick up genetic problems with that. So if I have a micropenis, a cryptorchidism coming, and a testes which are less than 1 ml in males, then the likelihood of finding the genetic yield is going to be bigger. In female, of course, as you know very well, we lack all these cues completely.
Thank you.
Excuse me.
Is that okay?
There's one more question.
Yeah. Hi.
Thank you, ma'am.
Ma'am, just to add one thing and also to ask whether obesity should be a pointer, because cases of Bardet-Biedl syndrome also come with, like, they have a presentation as hypogonadism or not. in clinical presentation.
So, would you say that obesity as a denominator is fairly large for me to work with?
Okay.
And would you also say that typically the obese children and their parents come to us for buried
Yeah.
penis in childhood or at early puberty, so to speak? So, getting into bodied beetle syndrome would have additional cues that I would like to work with, and I wouldn't sort of go ahead with anything to do with obesity alone as my denominator, as a pointer towards hypogonadotropism, really speaking. So I may not be able to use obesity as my punchline, but obesity with associated cues towards baribedal, I'm very happy to work with it, but not just obesity, which is like literally, I'm talking about 20% of children with obesity. So I may not be able to use that as my cue.
Yeah, thank you.
Thank you, ma'am. If I can just ask one question here.
Hi.
It's here. So, after having understood the 20 and the 30% yield, in what proportion of patients or which patients would we go ahead with a genetic testing upfront, being it a normosmic CHH?
So I would sort of put it this way that Manjri has sort of taken a lot of pain to collate very painfully challenging patients that we had encountered in our department, and there she will show you that specifically, though it was a child, it was a 4-year-old child, one was a 3-month-old child, one was 10-month-old child. Even then, specifically, we went ahead for the genetics because we wanted to anchor that particular window towards maximizing their efficacy as a so-called window to manage their mini puberty. And that's how we had gone ahead with looking at the genetic. But if you look at a blanket statement of children who come to you with delayed puberty, and where you are thinking of isolated idiopathic hypogonadotropic hypogonadism, where would you do genetic and how is it going to change your management for your patients is a very difficult patient question to really answer. For example, some of my patients now with hypogonadotropic hypogonadism, they father the children. And their question was, should I check my child's genetic after having fathered that child, either antenatally or at birth, towards possibility of finding out whether there is any genetic background to this child as well. Now, many of these are autosomal dominant in inheritance with extraordinarily variable penetrance. And exactly what am I really going to do with that piece of information in a newborn baby unless I'm encountering challenges and red flags at mini puberty, which I want to then enhance towards management principles? We have not done it unless there is a therapeutic window attached to it. Yeah. I do see Margaret somewhere. I saw her. Margaret, you're not visible. Only your halo is visible. Yeah, now I see you. So, yeah, so you're going to help out, right? If you had any
she was
contrary
kind,
comments
yeah.
to it.
She was kind enough to come in the front, so I'm also looking forward to her comments.
Yeah, I couldn't see her. I just saw some. Yeah. May I have the slides, please? Yeah. So when I talk about, hypogonadotropic hypogonadism, one of the things that we really, really get worried about is any of these secondary causes, right? I mean, these are going to change the management so much for the children, and that's what you want to really figure out, that it is really, is it acquired cause, is it secondary to something? Like our top panel is craniopharyngioma and our bottom panel is related to a giant prolactinoma which is sitting out there, both of them young adolescents who have actually presented for delayed puberty, and that understandably is going to change their entire priority of management completely for both these patients, right from maybe surgical in craniopharyngioma, and in our giant prolactinoma, it was more of anchoring the patient with cabergoline. So that would be one of the basic requirement when we are looking at patients with hypogonadotropic hypogonadism. And having gone through this as A, pubertal events, and B, the commonest cause which you want to distinguish is whether this is self-limited constitutional delay versus permanent state of idiopathic hypogonadotropic hypogonadism. You know that you have this battery of investigations which are available to anchor each of the domain of function respectively. So for hypothalamic pituitary axis, you have a set of investigations as narrated over there. For Sertoli cell function and for the Leydig cell function respectively, you have tests which are available. Most of us can do all these tests, barring certain very, very sort of evolved battery of tests like kisspeptin stimulation test. Now, that's perhaps not going to be possible for most of us. But what really needs to be realized and understood is how does one use these tests effectively? And are these kind of how fail safe are these test parameters in assigning a label or a diagnosis to a child? So even amongst all these papers which are published towards various aspects of the test parameters, one needs to be very conscious of the fact that the clinical cues still stand very, very powerful. This is one of the paper, a very good paper, which talked about how does one effectively start using testosterone priming towards all the test parameters yield being bettered versus the pre-testosterone priming. A very good paper published in Clinical Endocrinology 2017. But what we'd like to point out is the fact that just the height standard deviation scores and the testicular volume also talk to you a huge deal. So if you have a shorter individual with a little better testicular volume compared to a taller individual with poorer testicular volume, you do have a fair differentiating ability between a constitutional delay and idiopathic hypogonadotropism. So I think clinical cues should always be respected and should be sort of used effectively in our armamentarium. The test parameters in terms of GnRH stimulation tests, HCG stimulation tests have been around for a very, very long time. And this is one of the paper which is really, really kind of one of the older papers coming from Mehul Dattani and his team. I think it's about 15 or 20 years old paper talking about two groups of different constitutional delay and hypogonadotropism, and they carried out these three types of tests: HCG short stimulation, long stimulation, and GnRH, to show us that effectively when you do combined results of these test parameters, you get 100% sensitivity and specificity. I'm just giving you the data as it stands in these papers. We'll just see the application of this data, which is a more difficult job, and that's why specifically Manjari is going to do that. So also inhibin B, we talk about role of basal inhibin B. We talk about post-testosterone primed inhibin B levels and its sort of enhanced value or outcome over the basal inhibin B. We also talk about FSH primed inhibin B and its incremental value towards over and above the basal inhibin B. And here is a table which collates the data from different papers to give you the diagnostic yield of inhibin B in different scenarios. And especially we have quoted two different papers, again from 2017 and 2021. But again, we should realize and respect the fact it will entirely depend upon what kind of cohort you're dealing with. It cannot be universally applied, and which is what will come through in our case capsules very effectively. This is one of the very sort of evolved kind of a test which talks about kisspeptin stimulated, primed, GnRH primed, kisspeptin stimulated inhibin B level, done by Seminara in our group 2020 JCM publication, clearly demarcating the green area and the red areas very differentially, the green area being constitutional delay, whereas the red area being, the patients who did not progress to puberty because they were hypogonadotropic hypogonadism. Small subset of patients, but showing a tool of effective use of kisspeptin as well in assessing hypothalamo pituitary axis function. And after talking about these test parameters, which is variantly described as GnRH stimulation test or GnRH analog based stimulation test, different set of cutoffs which are available for that. Inhibin B in its nascent form, which is basal, testosterone prime, FSH prime, or talking about just basal values of FSH, LH, and testosterone with or without HCG stimulated testosterone. All these test parameters and its application is what Manjari is going to highlight now.
So, Madam clearly told us the varied tests which are available, the dynamic testing which is available to diagnose and differentiate between constitutional delay of growth and puberty versus a hypogonadotropic hypogonadism. I will tell you the scenarios where these tests actually failed us in making the diagnosis. So this is a boy who is 14 years 7 months old, and he presents with poor secondary sexual characteristics and small sized genitals. His height centiles are good. He's at a 50th centile. And if you see the SMR Tanner staging is Tanner stage 1. And the FSH, LH are low, and so is the testosterone. Now, we did do a basal inhibin B level in this patient, and it was 106. Therefore, if you go back and look at the cutoffs which I have presented here below, a basal inhibin B more than 80 is fairly sensitive and specific and is in favor of constitutional delay of growth and puberty. And therefore, this gave us the conviction to follow this patient up without doing any interventions. And subsequently, if you can see, he progressed beautifully through puberty, and at the age of 16 and a half years, his testicular volume had reached a size of 10 cc, and so was his testosterone, which was 2.7 nanogram per ml. So this is where inhibin B, just at the basal level, helped us without doing any kind of stimulation tests. This was one such case. Moving on to this second set of siblings, one who presents at 5 years and the second at 3 years, both of them come to us with a complaint of micropenis. Now, if you look at the HCG stimulated testosterone levels and the GnRH stimulated LH levels in both of these, they are crossing the cutoffs. Both of them have gone more than 1.04, which is described as a cutoff for the diagnosis of hypo. So both of them have passed the test in terms of HCG stimulated testosterone as well as the GnRH stimulated LH levels, which have crossed 2.8. But since they were a set of siblings who came to us with micropenis and they did have red flags, therefore we went ahead and did a genetic diagnosis in them, and they turned out to be homozygous for KIS1R mutation. So this is where these tests failed us, and in fact genetics was what helped us, and therefore we could treat these patients subsequently as they were genetically diagnosed and confirmed cases of hypogonadotropic hypogonadism. Another similar case is this 1.5-year-old boy who has all the red flags of hypogonadotropic hypogonadism. He comes with cryptorchidism and micropenis, for which he has undergone orchidopexy, and his levels at basal levels at 1.5 years are low. He is given treatment with testosterone, and his SPL increases from 1.5 to 3.5 centimeters over 2 years. Subsequently, he again presents to us at 4.5 years of age, and he undergoes a HCG stimulated testosterone levels, and we also do a prolonged HCG stimulation test in him. And if you can see, he has passed both these. The testosterone has gone at day 4 to 1.2, and also the day 22 testosterone, which has gone to 3.37 nanogram per ml. So we do still keep this patient under follow-up. And then subsequently, he comes to us at 12.5 years of age. His height is at the 25th centile, and he is still prepubertal as far as his SMR is concerned. So what do we do next with this patient? Is he a patient of CDGP, or is he a patient of hypogonadotropic hypogonadism? So therefore, we do an MRI of this patient, and he has hypoplastic olfactory bulbs. So again, a red flag sign pointing towards hypogonadotropic hypogonadism. So we looked back and we asked a detailed history of anosmia in this patient. And this patient did give us a history of hyposmia, that he couldn't smell what his peers could or what his sibling could. And therefore, again, we went ahead and also did an inhibin B at the basal level, which was low. But we also did an FSH stimulated inhibin B, which again crossed the cutoff, and it went up to 143 nanogram per ml. And also the GnRH stimulated LH levels at 2 hours, which stayed somewhere around the cutoff of 2.8. So this patient is genetically negative. So although he has all the red flags of hypogonadotropic hypogonadism, he passed all the tests which are described to distinguish between a congenital constitutional delay of growth and puberty versus a hypo. This patient, however, did not progress further through puberty, so we put him under treatment with recombinant FSH and HCG, and subsequently he is currently 15 years of age, and his testicular volume is 8 to 10 cc with a good serum testosterone of 5.7, although he's receiving treatment for the same. So therefore, all these dynamic tests should be used with caution. And if you have any red flags which are pointing towards hypogonadotropic hypogonadism, you should rely probably more on the clinical signs, and always keep these patients under follow-up so as to not miss patients with hypo because of these cutoffs which are utilized.
So I really think that the last patient was the most informative of all. And I mean, because he came to us right in infancy and then in childhood, 1 year of age and at 4 years of age, we couldn't sort of, illustrate the history of anosmia. But when he came back now, we could clearly understand that he used to be anosmic, really. I mean, there were instances and all the sort of scenarios that he described, he couldn't smell. And that is when the whole thing became much more clearer, that his olfactory bulb hypoplasias, his micropenis at birth, bilateral cryptorchidism, which was all fixed, and then the surgeon had sent the patient to us, was all part of hypogonadotropic hypogonadism. There was no family history, there was no non-reproductive phenotype that was available, but it's 15 years of follow-up, and at puberty, his arm span was already showing it was longer than his height, coupled with the fact that he had not entered puberty, though he passed all the test parameters and their so-called cutoffs, is the child who actually had hypogonadotropic hypogonadism, and that's where he stands. What it really tries to illustrate is that these tests will have their limitations. It will entirely depend upon what kind of patient population these tests have been studied into. So if you take severe cases of hypogonadotropic hypogonadism, where the testicular volumes are less than 1 ml, and if you take constitutional delay on other hand, the performance of two different scenarios are going to be black and white. But the minute you start taking a partial state of hypogonadotropic hypogonadism, the performance of these tests will become poorer. And that's what we wanted to show you in this next particular study. And this is a fairly good study, which I think is meritorious of being mentioned over here, done by Shak Young and his colleagues. And these are fairly large number of individuals that were studied. That is one of the strength of the paper as well, because if you start studying patients in 20s and 30s versus 130, there is going to be a little bit of difference in the data strength that you're going to generate. And also, by point of inclusion, they had taken a full spectrum of hypogonadotropism, not just children. The previous studies had encountered only childhood cases of hypogonadotropism, which by and large would present in childhood only because they are severe. If they are partial phenotype, they will not present in childhood. They'll come in adulthood, and that's where the whole distinction gets lost. And this study because it included the full spectrum of hypogonadotropism, what it actually showed in the first half of the slide, if you look at the performance of LH, it clearly suggests that though in constitutional delay, GnRH stimulated LH, hardly ever anybody goes below 4. Above 4, when you use as a cutoff, 45% of hypogonadotropic hypogonadism will rise to that level. So you will not be able to differentiate that. Also, as the testicular volume progresses, the distinction between the constitutional delay and hypogonadotropism towards LH, which is stimulated by GnRH test, starts getting blurred. And that's where the yield of the test suffers. And that's what is being highlighted by the top panel. The same thing happens by inhibin B as well. So these test performances are based on, do you use GnRH or you use its analog, which are more potent and hence probably give a bigger rise. And that's why you cannot use the cutoff which are used for GnRH stimulated tests for its analogs on one hand, nor can you really apply the data from severe phenotype to the partial phenotypes. So that was a learning part, A from the cases and B from the studies that we wanted to highlight over here. Coming back to our two famous case scenarios, constitutional delay versus, which is a temporary physiological delay, versus permanent state of hypogonadotropism and its treatment. Do you really need to treat constitutional delay, or do you just allow it to progress through puberty? Well, it's going to depend upon what exactly are you trying to do. If you are at peace with yourself, and if you can put the parent and the child at peace, maybe you don't need to treat it at all. But if some parent and the child both want it to be either pushed or pulled, you have an option of using either letrozole or testosterone. Are the results very different? Well, the letrozole gives you immediate increment factor in the testicular volume compared to the testosterone based therapy, the red bar being letrozole and the blue bar being testosterone. But the height velocity increment is better with testosterone. But at the end of 1 year of treatment, the testicular volume and the height velocity differences between the two modes of treatment are not very huge. So it depends on you how you want to structure your thinking and management of these group of individuals. If we are now talking about managing permanent state of hypogonadotropism, we should be careful even at this age and this stage that we may encounter very unusual causes beyond what we've talked so far, and that is always a jolt that one goes through in departments. And this is the first patient that we encountered. It was a case of adult male with normal genitalia presenting with delayed puberty and the testicular volume, which was 8 to 10 ml, to be having actually Leydig cell hypoplasia syndrome. And on the other panel, the two brothers, again adults, who presented with 18 ml of testes with now halting of puberty, is basically related to 17 alpha hydroxylase insufficiency. So these are going to come through as surprise elements, and one will always be careful about it, because again, your management, your outlook, and your prognosis, everything is going to change in these patients. The basic management related to hypogonadotropism, whether you want to work with testosterone alone as something which builds towards secondary sexual characteristics, the height of an individual, the muscle mass of the individual, the psychological aspects of the puberty, and the bone strength of pubertal events, is very simple, and there are many formulations of testosterone which are now available, including subcutaneous testosterone, which is now going to be available. So that is something very standardized and really, I think, does not merit any discussion. What we would like to consider and address over here is that, do these children, even when they come to you as delayed onset of puberty, where fertility is a far-fetched milestone for them, still are meritorious of gonadotropin-based regime? And that's a question we want to ask ourselves. Now, this question is asked and answered many a times. And this question is as old as being sort of answered 45 years ago. This is a reference of 1979. So it's not a new question, not a new concept that we're talking about. It's just, I think the understanding of it and the outcome based understanding of it has changed over a period of time. And this was the standardized protocol that we used to use even for pubertal induction, till we realized the questions which remain unanswered at the end of this protocol, which was combined regimen of HMG and HCG, which was used from 0 hours in these patients, and then stepwise increments were being introduced. We realized that in severe phenotype of hypogonadotropic hypogonadism, our results were poorer. And that's where we wanted to kind of get a betterment coming in. And that's where we understood how to go about it. So here is what we used to do with our protocol and its outcome. A 14-year-old who came to us, and again, Ashima, you'll realize we did the genetics here because we wanted to be doubly sure. Though this patient was very clear, he was completely anosmic in his sense of smell, and people used to make fun of him in the class because he was so anosmic. And he had a proven Calvin mutation. We took him through this standardized protocol. He has now come with a testicular volume of 12 to 15 ml, with semen analysis which shows a total sperm count of 10.5. We have sort of advised him that he should be banking the semen, and now he's opted to go up to testosterone-based regimen. This is what he looked like when he came to us, and this is what he felt like when he left our clinic after about 4 or 5 years. Feels very comfortable and confident as a young man now. Also, sort of extrapolating this into other end of the spectrum, a young infant of 3 months and 11 months and a 10-year-old, each of them with clearly defined state of hypogonadism, either proven through clinical picture and aided in by the genetic respectively in each of them, were also treated as shown in this paper over here, and mini puberty, which is what was flagged out in our 3 patients previously, what we showed you and described to you. So whether mini puberty is a state of opportunity for these individuals, where based on the red flags of micropenis and cryptorchidism, you will be carefully considering a possibility of DST, excluding it, proving your diagnosis of idiopathic, isolated, or multipituitary hormone based insufficiency state, and may consider management with gonadotropin, is a question which is not translated into uniform understanding or sort of a guideline, but this is what we have done in our patients, and I wanted to share it with you. Again, question time.
So just to remind, we have remaining 3 minutes, I think,
Is
for
it?
this session.
Okay.
Yes.
Okay. So shall we just continue it and maybe
So-
see if there are time
Yes.
permits?
Yes,
Yeah?
sure.
Sorry. So what we learned as a predictor of fertility is the testicular volume. And towards that, what we have learned is that patients who present with severe phenotype with very small testes are the patients who don't do well, either in Leydig cell function or even in Sertoli cell function and the sperm count building, as sort of one of the areas. And these are the patients who perhaps benefit with HMG pretreatment or RFSH based pretreatment. And that's what we have learned. And there is several data which support that. And hence our protocol has been now modified to use HMG or RFSH based pre-treatment titrated with inhibin B, get it optimized, and then introduce HCG in our group of individuals. So perhaps prior testosterone alone as a therapeutic option for these patients may not be a very welcome suggestion, especially in a severe phenotype, is what we would like to suggest. So FSH pretreatment in a severe phenotype is one area which merits consideration, whereas an acquired phenotype who've already gone through mini puberty and may have an FSH sparing effect, who kind of come with partial phenotype, may do better as outcome based parameters, especially as it relates to spermatogenesis and fertility, is what is another learning point that we have gone through. So clinical cues are important because at the end of the day, all of us are clinicians. Gonadotropin based therapeutic aspects are useful in managing infant with micropenis, even in testicular descent in cryptorchidism, pubertal induction, and fertility, and maybe in a severe phenotype, FSH pretreatment is one of the window of opportunity. Thank you so much.
Thank you. Thank you, ma'am, for putting it all very well together. And I think we've discussed most of the contentious points that we face. So if there are any quick comments, questions, we have 2 minutes, perhaps not more than that.
Wonderful discussion, ma'am. So I have a doubt on the routine usage of HCG versus recombinant HCG, the stimulation test. What is your opinion on that?
On the stimulation test?
Yeah, the HUCOG or the recombinant HUCOG?
So we never used to really mind either of them until some time ago, actually speaking, and we realized that many of our patients on just HUCOG were not doing well. They just were not making testosterone, which is one of the simplest function in managing hypogonadotropic hypogonadism. Leading cell function and its management is not as challenging as managing Sertoli cell and spermatogenesis, really speaking. And that's when we realized that this formulation sort of was going through some area of trouble. And then onwards, we've shifted over to recombinant HCG as a management principle. So it is both for the test and for the treatment.
Because
that we
there's a
shifted
cost
over.
difference. HCG is just 400 and this is 1600. So
I hear you. I relate to you.
Yes.
I'm with you.
Yes, ma'am. Thank you.
Ashima, one question.
Sure.
Dr. Manjari, you had presented a case of two siblings who turned out to have KIS1 receptor mutation. So, one thing was, what was the testicular volume in those two siblings? Because I think you forgot to mention. Did they have cryptorchidism, or was the testis descended? And was the mutation homozygous or dominant?
Yeah, so it was a homozygous OKIS1R receptor mutation. Both of the children were not cryptorchid. They had bilaterally descended testes, although the testicular volume was less than 1 ml in both these patients. And both of them had micropenis at presentation.
Okay, so testicular volume less than 1 ml, I think we also
So
find
1
that that is a
Yes.
very
You know,
good
but
pointer.
I don't know, Bandana, how comfortable you feel. 1 ml,
Yeah,
less than 1 ml.
exactly.
So it is-
You know,
For
I
very
mean,
small children, it's very
I
difficult
kind
to
of,
say 1 ml, 2 ml, but yes,
so
I
my
do get your
level of
point.
strength over there kind of starts wavering. So I call it 1 ml. And but yes, they had micropenis, both of them, and that threw us off. I mean, the growth was pretty okay, conferring to mid-parental height. So we know that we were not dealing with growth hormone insufficiency state.
So,
We were
okay.
not. We were pretty sure that both the testes were bilaterally descended down. So we were not dealing with any state of DSD, so to speak. And we knew that we were erring towards hypogonadotropic hypogonadism, but our test parameters were not helping us. And a consanguineous marriage with two siblings and the genetic was sort of quite
And do
helpful.
heterozygotes present with CDGP like picture or partial
I don't
hypo
know.
like
I
picture?
don't know the answer to your question,
Okay.
but these were homozygous
Yeah,
mutation that we
like
had.
sometimes we get such a history in the father that
Yeah.
mother may say that I find that the penile length is less, or the father may say that I developed late. We have few such patients, but not genetically proven. So wanted to know that could heterozygotes present with that kind of a picture?
Your question was, did we go and study the parent and did we examine
Yeah,
the father?
yeah.
We have not done that. We have not yet done that.
Thank you. I think we'll just have one last comment from Sirisha, ma'am, and then we can close.
Thank you, ma'am.
Sirisha is there.
Sirisha here, ma'am. Thank you.
Yeah, hi.
My question is on mini puberty, induction of mini puberty. Most of our children, say for example, a case of multiple pituitary hormone deficiency, they do present to us a bit later in terms of assessment of hypogonadism. What is your cutoff before, when we can consider induction of mini puberty? Is it like just 6 months, 10 months? What if they come at 1 year
So let's
with
understand.
cryptorchidism, say?
So if there is a micropenis and cryptorchidism, I mean, you're talking about the ideal so-called age of presentation being 9 months or less than 1 year. But irrespective of when they present to me, and if I'm certain this is hypogonadotropic hypogonadism that I'm dealing with, I will go ahead and do that. So my first case that the third case which Manjri showed us, that child has now got 16 years of follow-up. When he presented first time at 1.5 years of age, if you notice, his micropenis was treated with testosterone at that time. That time we were not practicing treatment with gonadotropins as the anchor for mini puberty and its management. But if that child came to us today, even at 1.5 year, I would have done that. We did the same thing for our 10-year-old child. Cryptorchidism, micropenis, we treated him with gonadotropin. With HMG pre-treatment itself, the testes had descended down. So
Thank you, ma'am.
So the three cases which we presented here, all three of them were beyond. One was an neonate. Both the other two cases were beyond infancy. One was 11 months old. The other one was 10-year-old. So we have induced mini puberty even in
Still
these
use-
patients.
yeah.
Yes.
Thank you.
Thank you all. Thank you. Thank you, speakers.
you.
Thank you, ma'am. Thank you, Dr. Manjari, for an excellent session. We'll
Thank
have
you.
time for coming back to ma'am tomorrow also when she has the Meet the Expert session again. So I'm sure most of us would still have more questions. We can maybe catch up with ma'am tomorrow. Thank you all.